Good evening, Kenya. Tonight we come to you live from the heart of the nation, our capital, Nairobi, where the conversation around healthcare reform has reached a critical tipping point. Over the past 6 months, from October 2024 to now, April 2025, millions of Kenyans across social media and community forums have been exposed to ongoing conversations around the Social Health Authority, SHA. Yet, despite its massive digital footprint, public engagement remains overwhelmingly negative, with only 1 in 10 people reflecting optimism or support. At the center of these growing frustrations are concerns around finances, government accountability, and persistent challenges in the state of healthcare delivery in our country. December saw tensions rise, with a report pointing to a 104 billion Kenya shilling procurement of the SHA system. We'll get to hear more about that. Then, in March, was SHA's announcement on the changes in the means testing process, reflecting or affecting premium contributions due from non-salaried Kenyans. And while public trust may be shaky, interest remains high. On the Willow Health Media website, for example, stories on SHA have consistently remained in the top 10 month after month. Kenyans want to know how to register, how to pay, and what SHA really means. Questions, concerns, and comments keep flowing in. From YouTube guides on SHA registration to heartfelt comments from Kenyans living with chronic illness, the message is clear. Kenyans are engaging. They are demanding clarity, transparency, and better service. They're hungry for authentic and authoritative information, and that's where we come in as Willow. Willow Health Media is the first ever health and science newsroom in Kenya and in the region. Our mission is to deliver fresh, authoritative, and impactful content to you. Tonight's Willow SHA Town Hall is a special edition brought to you by Willow Lifeline Dialogues. And this evening, we bring the conversation home, to the people, to you. This is not just about policy. It's about lives, livelihoods, and the future of our healthcare system. I'll be your host for the next hour and a half. My name is Dr. Korir, the CEO and Editor-in-Chief of Willow Health Media. Our panelists this evening are Dr. Abdi Mohamed, who is the Chairperson of the Social Health Authority. Dr. Mohamed is a seasoned healthcare executive, entrepreneur, and a policy advocate. He's a medical doctor and has held key leadership roles, including the chair of the Kenya Association of Private Hospitals and an independent director at Willow, Kenya. He was appointed the SHA chairman in September 2024 by President William Ruto. Next is Dr. Mutakha Kangu, who is a constitutional law expert. Dr. Kangu is a distinguished Kenyan legal mind, academic, and author, renowned for his pivotal role in shaping Kenya's devolved governance. He is a senior lecturer at the Moi University School of Law. As a commissioner on the Constitution of Kenya Review Commission and chair of the Task Force on Devolved Governance, he played a key role in drafting the 2010 Constitution. Next is Dr. Kanyenje Gakombe, who is the chairman of the Kenya Health Care Federation and the CEO of the Metropolitan Group of Hospitals in Nairobi. He founded Metropolitan Hospital in 1995 to provide quality, affordable healthcare to Nairobi's middle class. He is passionate about integrating technology in healthcare and has been instrumental in developing hospital information management systems to enhance efficiency and patient care. Last but not least is Dr. Anita Musiega, who is a health economist and health systems expert. She currently serves as a postdoctoral researcher in health economics at the Kemri Wellcome Trust Research Program in Nairobi. Until January 2025, she also served as a health economist consultant with the USAID Health, Population and Nutrition Office. She's a founding member and the current treasurer of the Health Economics Association of Kenya, actively contributing to the advancement of discipline and practice in the region? Thank you very much. And our very first question goes to Dr. Abdi. And this is based on, the questions that we get online, not just as Willow, but also what we see. Many people are wondering why they need to register for SHA. And the reason being that primary health care is free to access. Emergency, chronic, and critical illness fund is free to access. So why do they need to register?
Thank you very much for this invitation. Why do you need to register? There are many reasons why we need for you to register. The first thing is we use the registration and the number of people who have registered to budget for. So for you to get the primary health care, the first thing is to know the number of people who have registered, and that's how you get that budget. The second thing is to identify you when you seek care in an institution. Because the truth and the reality is there's a lot of fraud. If we just allow people to show up in hospitals without having a way of identifying them, then we will run into the trouble of getting claims that cannot be supported. The third thing is just to get that unique identity. And what we have done is we are not asking Kenyans to give us biometrics. We have linked that to the National Bureau of Registration. So your fingerprints that you have given during when you are picking your national ID is what we are using. So that gives us the unique identifier as the single source of truth for the database. So that's some of the main reasons why we ask people to register so that they can access the free primary health care.
But by law, or how the fund has been, the authority has been established, primary health care should be accessible by all. Emergency care, even by the Constitution, is accessible by all. So whether I'm registered or not, I'm entitled to primary care and emergency care. Why do I need to register for that?
For emergency, yes, you don't need to register. But for primary, because providers need to seek that claim to come to SHA. How do we identify what claim is real and what services have been offered? So how are you identified at the facility level? And that's why we are asking Kenyans, just register, and it doesn't take a lot of time. Very simple process from your phone. You don't need to go to any branch to do the registration. You don't need to fill in any form. You just dial from your phone *147#. And if you are tech savvy a little bit, you can go to afyayangu.go.ke. That's enough. And you can do all that from the comfort of your home. That's how much easier we have made it. And the other thing that we have done is we have allowed community health promoters to assist. There is the assisted journey for registration. That also adds another layer for people who might not have access to phones or who might not know how to go about it.
Let me bring in Dr. Kangu, still on the registration bit, and whether the establishment of the Social Health Authority is in line with our constitution and our right to health, in that for me to access certain parts of healthcare, it's pegged on my registration and further to payment of premiums. So is it in line with the constitution?
Our constitution has been lauded as very transformative. And if you look at the aspects that make it look very transformative. Number one is devolution. Number two is the Bill of Rights. And the Bill of Rights, if you look at it in the context of the retired Constitution, you'll be able to say that the retired Constitution was limited to what we called civil and political rights. It didn't provide for socio-economic rights. The current Constitution, Article 43, provides for what are called socio-economic rights. And from the lawyer's perspective, before I started interacting with health, I was looking at Article 43 as having a section on you having the right to the highest quality of health, including reproductive health, and then, of course, other rights to do with the housing, the right to food, the right to education, water and sanitation, and so on, quality water. And then, of course, there is a sub-article of that article that is very emphatic that nobody should be denied emergency medical services. So that means that whether you can pay or not, emergency medical services should be made available to everybody. But of course, interacting with health for the past 4 years, I now hold the view that the whole of Article 43 is about health. Because if you look at health from the broad perspective that includes the health determinants, then you will see that the other rights we look at under Article 43 as, say, water and sanitation, is a major determinant of health. So the right to water and sanitation, to my view, is still about health. The right to food is a major determinant to health, so it's still about health. Issues to do with the decent housing, they are all about health. So I've come these days to conclude that the whole article is about health, and especially if you take into account the reforms that we have said we are trying to undertake, which are even talking about trying to shift from over-concentration on curative and now expand the arena and invest more in promotion and prevention, then you see that right is very important. But the question of registration, my big problem is not even with the registration. My big problem, and I don't know whether Daktari will be able to tell us whether they have now changed, because I know that they would say all you need is to register, you don't have to pay. Mm-hmm. But the registration system on the system, you start logging in, and at the end of the process, it pops out an invoice for you. Yes. So if you don't pay, you don't complete your registration. So that leads you to problems. But then, of course, the constitutionality of that is that I critiqued the law from the time when it was being proposed as a draft. Because we said in that law that we are going to make social health insurance compulsory. And I asked my colleagues, how are we going to enforce? If people don't have money to pay, they will not pay. So it's not enough for you to say in the law, it is mandatory. Because the basic of the concept of insurance is that it's based on voluntary contributions. So it doesn't matter that you have said it is mandatory. Of course, they say, no, we will put there a clause that if you don't register and pay, then you will not access other government services, all government services, national government, county government, and you will not even access health services. I said, but then you can't be saying you want to avail the right to health, and in the process, you are infringing the other rights. And I said, you will make parents who had increased registration of children in schools go back, because you will tell them, if you are not paid up under SHA, you can't access other services of government. Of course, that issue is still pending in this Court of Appeal. They were taken to court, and the High Court, in my assessment, was very generous. Because they said they had demonstrated that there was sufficient ground to limit the rights. And the only thing they were very concerned about was that, but you can't limit the right to emergency medical services. As to whether they will succeed in the Court of Appeal on that, I don't know. But my view is that the High Court was generous, because if we go by that ruling of the High Court, you can believe that in our effort to enforce social healthy rights, we are going to deny Kenyans very many other rights. Many people who will be unable to pay for social health, and now you are telling them you can't take your children to school, you can't go. And I one day joked that payment of taxes is a government service. So are you going to stop us from paying taxes because we have not registered for social health? Because you have said we should not access any other government services. It will be counterproductive.
Hold that thought. We'll come to the taxes bit, because I know you have talked about the health reforms being money bills and money acts. So I want to go to Dr. Gakombe as a healthcare provider, and you represent other healthcare providers. Has the implementation or the transition from NHIF to SHA impacted healthcare providers, and especially in light of what Dr. Abdi has said, what Dr. Kangu has said, in that if you're not paid up, you're limited in accessing other services. So has it impacted the quality of care for your members, that your members are providing to Kenyans?
As the chair of the Kenya Healthcare Federation, we bring together the healthcare delivery, the healthcare ecosystem, all the way from providers to manufacturers of healthcare commodities. The answer to your question is like professors, it's yes or no. Because we didn't come from a vacuum, we transited from NHIF to SHA. NHIF, in spite of the many people who are missing it, had its own set of problems. And one of those problems is that providers like me and my sister from MP SHA were the underwriters to NHIF's financial difficulties. And of course, all the doctors we practice with. And that's why right now we're having a conversation about bills that go back to 2016 that were not paid, right? So to that extent, the past was not glorious for providers. And it was affecting both quality and access. Quality because once bills are not paid, then we cannot access commodities, we cannot access healthcare workers, and I'm speaking especially for all sectors, all providers, because even the county ones, although the infrastructure is in place, they also need money. But the transition came with its own challenges, because first we transited to a new system, and that meant credentials, that meant training, and during that process, there were people who could not access service. Because providers were worried about how they'll get paid, when they'll get paid, and we are coming from an environment where payments were not happening anyway. Secondly, the members themselves were being transited from the old data to the new system. So we had dual trouble. Providers who are learning how to use a new system and being introduced to it, and members who were supposed to access service who were also being transited to a new system. That problem has generally been solved now. We are dealing with, we still have challenges, but we are dealing with a different set of challenges. We tried very hard as providers to ensure that those who needed long-term care, like dialysis, and those who are on cancer treatment, were not affected by the disruption during the changeover. And by and large, many of them continue to access service, but there definitely was a challenge in the beginning with patients getting access for the reasons that I've stated. We've moved on, but we've also seen that because of the old debt, there are providers who have been on go-slows, asking to be paid their money. But the money that is fundamentally in dispute and in question is money that was owed at the NHIF. SHA is basically, as an inheritor of NHIF, inherited that challenge, and providers want assurance that they'll get their money. So we've had about 4 go-slows, we've had disruption, but most of it is carryover from NHIF.
So if SHA inherited, not if, SHA inherited the assets and liabilities of NHIF, why wouldn't they pay? Or we take that to Dr. Abdi?
As far as we are concerned, it's their debt 100%. It was disingenuous of them for somebody to say it's not their debt, because then they should have given us a building to sell. Because where was our money? Our money was in the offices that we're sitting in. It was in the parking lot. It was in the land in Karen. So they say they took on those ones, but our money is not quite owed. So even now, if push comes to shove, would like to remind the chair that the building and all the assets that were handed over fundamentally belonged to providers who are underwriting the outstanding amount to date.
Abdi, I'll come to you to tell us, or you will quickly answer why you haven't paid the providers. Because the go-slows ultimately affect Kenyans who are seeking services from these facilities.
Actually, there are many things I wanted to answer, but just on that one.
Just on that one, then we'll come back to you.
Yes. In 2018, the Ministry of Health constituted a panel of experts. And in 2019, they produced a report called the NHIF We Want. In that report, it said NHIF will collapse in 2020. Why? The claims were higher than the income. Google that report right now, and you will see it. The graph shows income downwards, expenses on the roof. It also said in 2022, and that was just the national scheme that they said will collapse, but in 2022 they said the whole organization will not be viable. So what does it mean? If today we collect all the outstanding debt that is owed to NHIF, vis-a-vis the claims from providers, it will not balance. So the first thing that you need to keep in mind is this was just some sort of a Ponzi scheme. The little that comes in is what my brother was getting paid. So he was assuming that there's money that's coming. So it's just the hope that kept on making the providers that things are okay, because they used to get continuous payment. Vis-a-vis SHA, which has started, and that's the first thing that we have tried to address by the mandatory contribution, so that you have benefits that can be sustained by revenue. Otherwise, you will be lying to yourself. And NHIF suffered from that problem because it had many schemes that had more benefits than premium. So the premium that they were collecting was less than the benefits that they were giving. So that means that every time the payout ratio for the national scheme, especially the informal sector, was 2.9. For every 1 shilling that they received, they were paying 3 shillings out. If that is not a Ponzi scheme, I don't know what's a Ponzi scheme. It's impossible to receive 1 shilling and pay out 3 shillings. So what happens? My brother was just putting in his books, NHIF, NHIF, NHIF. But nonetheless, the government did not say that's not our debt.
Which is what the question is. Why are you not paying them now? Because you've owned up to the debt. Sell the land Dr. Kiki is talking about.
Even if we sell the building, we sell the land, we sell everything that SHA owns, it will not pay, I think, 2 or 3 hospitals. It's not enough to pay 2 or 3 hospitals, because some of the hospitals are owed 2 to 3 billion. A hospital, just one. So it's impossible. And one of the reasons why we wanted to find out is the minister has, the president committed that we will pay, because that is something that is owed to government and we cannot run away from it. So the only thing is the process on how to go about it. So the first thing is just to verify some of those claims. Claims which are below 10 million, which is owed to 91% of the hospitals, almost 6,000 hospitals, will be paid without verification. If they have stolen, whatever it is, it will be cleared. But claims that are above 10 million, which is owed to very few hospitals. When I say few, is around 500 hospitals in this country. That's what needs verification, and that process has started. But unfortunately, in this country, every time you want to get a solution, the courts somehow just come in. Someone runs to court and says, we should not verify. Pay as it is. Pay as it is means pay even the fake claims. And that brings a challenge.
We'll come to that. Let me bring in Dr. Anita about the SHA model, as you know it. 3 funds, 2 from the exchequer, 1 contributory. How does it compare with other universal health coverage systems, particularly in Africa, in terms of equity, efficiency, and the sustainability? Especially sustainability, because Abdi was saying NHIF would have collapsed by 2022. Yes.
Thanks, Dr. Masi, for having me here, and it's nice to hear Dr. Abdi's and the rest of the panelists' opinion. So just to start with, there is no perfect UHC system. There is no country that can claim to have achieved UHC, not the high-income countries, not the middle-income countries, and not the low-income countries. So as much as we are trying to figure this out, we are not alone in this. Everyone is trying to figure this out. Having said that, there's so much out there we can learn from. But even as we learn from other countries, there's so much contextual differences, which means that not everything that other people do, we can do. Let's start with Rwanda. They have a community-based health insurance. As at last year, 91% of the population was registered, compared to Kenya's, I'm not sure, Abdi, but the last I checked was about 40% if you add the dependents, about 40%. Slightly better than NHIF, which closed at 24%. Let's go to Ghana. They have about 65% of their population registered. So if you think about equity in terms of population coverage, are you able to cover most of the population? So I can say we are at about 50%. We could do better. And then when it comes to pro-poor, like in Rwanda, they pay for the poor. In Ghana, 70% of the people who are registered are actually paid for by government. In Kenya, we have an interesting model. So it's very hard to say what exactly is the percentage covered by government, because 100% of the Kenyan population is covered under the PHC fund. It doesn't matter whether or not you're paid up, you still should and must access the PHC fund. All you'll have to do is register. And I wanted to say there's a difference between being registered and being paid up. So to register is to provide your documentation. So that guarantees you access to the PHC fund. And for the Emergency Chronic and Critical Illness Fund, you don't even need to be registered. You just need to live in Kenya. So the problem where we have serious equity issues is the Social Health Insurance Fund. And the government had said for the poor who are identified, they will pay for those. I am not sure that we have, at this point, paid for any poor people. I'm not sure the county governments have paid for any, or the national government, but that must be addressed for us to say that we have an equitable system. And of course, there are challenges with the proxy means testing in terms of how much does it actually ask you to pay. I know it's been on record that we will pay a minimum of 300 shillings, but if Dr. Abdi is honest, he will tell you 300 shillings is not sustainable. 300 shillings per Kenyan cannot buy the package that we intend to buy. So they'll tell you the correct, if you look at the previous benefit advisory panel that was set up by Uhuru Kenyatta, His Excellency Uhuru Kenyatta, they came up with about 20,000 per household per year. 300 per household cannot work. I know SHA will tell you, if you ask them in behind the scenes, that they have come up with about 800. So we need to ask ourselves, can we be honest? In terms of efficiency, Ghana and Rwanda are doing way better than us. Efficiency in economic terms means you have this amount of money, what do you get out of it? How much health are you buying from it? So in Kenya, we are spending way more than all those countries per capita, but our outcomes do not match that. And that's not only for SHA, it's the entire healthcare system. We need to have that conversation. In terms of sustainability, as he had said, NHIF had their challenges. They were not sustainable. And the challenges with sustainability go down all the way to the individuals. An insurance system is based on pooling. When you, as a Kenyan, go and register just for the sake of your bill being paid, you're part of the reason why the insurance system is failing. Because you pay 500 shillings and you expect SHA to pay for you a bill of 500,000. Where does the 499,500 come from, unless as a Kenyan you pay throughout? So Kenyans, we are part of the problem. And if SHA will not work, it's because of such things. The informal sector, you come and pay 100 bob, then, or you pay 200 or 300, you access the service, and then you drop out. So in terms of sustainability, even Rwanda is struggling. Some of their funds are from donors, and luckily SHA does not have money from donors. They are partly donor dependent, and we've seen how that is going with Trump decisions. Ghana, they also struggle because when the VAT, theirs is pegged on partly VAT, so when the economy does not do well, things go down. So those are the conversations that we need to have in terms of sustainability, efficiency, and equity. But we have a long way to go.
Thanks for that, Anita. I could see Dr. Abdi nodding, especially when you said Kenyans are the problem, they need to register. and I was wondering why, Dr. Abdi, you're still at about 21 million Kenyans. Why not even 90%? Because by law it's mandatory. So why are we not getting the numbers that Rwanda has in registration only, not even the being paid up?
SHA is 6 months old. You just need to realize that we have been beaten thinking that we have been in existence from 1960. She told you NHIF, which started from 1960-something, reached only 24%. SHA, with 6 months, is at 40-something%. That already tells you something. And the thing about health is something that you need from cradle to grave. From the time you are born to the time you die. Education is optional. Unaweza ishi na ujinga yako. It's not a must. But with health, you can't. And it's not divisible. If I am well and you are sick, I can't share my wellness. And that's the part that people need to understand, that as she clearly stated, there is no country that has a perfect UHC model. Every time we keep on hearing these other countries, you come to realize later what works for them can't work for you. And for Kenya, we have opted for a mixed model. A taxpayers funded part of it and contribution from individuals, a social health insurance. So this now gives us some benefits that when you go to other places and then you ask yourself, really? I saw in December, I follow the Ghana National Health Insurance Fund. It's called similar, NHIF. It's the first time that they were providing for dialysis, one session. And people kept on telling us that, oh, Ghana is at 74. Yes, 74%, but if you are not giving the benefits as required, it doesn't help anyone. And I think she has explained that, yes, you might move all the way to the end of registration and it gives you premium. That premium now is what takes you to the second layer, the second fund, which is the social health insurance fund. Now that allows you to access surgeries, dialysis, cancer treatment, when you need inpatient, maternity, all those things. So that gives you the second, become a member so that you are able to get your care being paid for. And the reason why NHIF also had a problem is the issue that she talked about on where you make it voluntary. Now, when you make it voluntary, what happens is people only pay when they are sick. Imagine getting a car insurance after an accident. Your car hits, is involved in an accident, the whole bonnet, the whole front is broken. Then now that's when you say, okay, let me pay 20,000 as my insurance, and then I ask the insurance to pay the repair, which is worth 300,000. Where will the insurance get that money from? So that's why we need to pool our risks. We need to pool the resources so that we are able now to expand the benefits that we give to Kenyans.
Okay. I want to take questions from the audience. I think we can start from the middle and then the one to my far right. If you have any question, you can raise your hand or even a comment, anything. We'll just
cue you for that. And as we do that, I want to ask Dr. Kangu about the mandatory nature of deductions and, people going through the proxy means testing to pay. Is it, and that is legislated, especially the 2.75%.
The mandatory. Yes, as Prof has said, the case is still in the court. Agreed with the mandatory nature of payment because they have understood the dual funding that we were legislated. But in the same law, we said government is supposed to pay for indigents. People who can't afford, it's the government. And Dr. Gakombe can tell you the county government from Murang'a has paid for 40,000 households. And that's what's supposed to happen. That's what we have captured in the law, that people who can't afford, can't pay, won't pay. It is the duty and the responsibility of both national government mainly, but there are county governments who would want to step in, pay for them. Finally, it is the minimum is 300. There are people who pay 3,000, 4,000, even in the informal sector. So it's not uniform 300, and that is the essence of it being ability to pay. So you pay based on your income, not equal. Because when you say equal, then you put people who earn little at a disadvantage. So it's ability to pay, and we are all paying the same amount in terms of the same percentage, and that makes us equal in terms of how we are contributing to the fund.
So yes, my question was on the contributions to Dr. Kangu. It's legislated, it's in law. Were there any other legal alternatives that would have been better to raise funds towards SHA, the Social Health Authority, for any of the funds? Say even the VAT that is in Ghana, or like what we do with the road maintenance levy from fuel. Were there any other creative ways of raising funds without raiding the pockets of Kenyans directly?
Now, thank you. Maybe I should begin where Dr. Abdi mentioned what was the problem with NHIF. And he correctly pointed out that the problem was the unsustainability of NHIF because we could not be able to easily enforce contributions from the informal sector. Looking at the statistics, the Kenyan formal sector, which has salaried people, is just about 17%. Previously, I used to think about 20, but now I've seen some statistics that are talking about 17%. And so, we are a country that sets off to say we want to solve a problem and clearly avoid solving that problem. Because if we know that the problem under NHIF was we couldn't raise enough money from the people in the informal sector, because Kenyans have learned how to even lie about payment of taxes. They know how to play around with figures. And if you read Robert Kiyosaki's books, he will tell you people in business, they are allowed to first spend and then choose whether to declare whether they made profit before they pay tax. they are able to declare they have not made any profit. But people in salary, you are the unfortunate one who must pay government tax before they let you to spend the rest. So that was the problem with the NHIF, and we have not solved that problem because that is what SHA is now facing. They can't collect enough money from the people in the informal sector. And I've emphasized that it's not that by being in the informal sector in this country, you are poor. Actually, many are very rich. Go to these slums and you'll find there Amze seated in a kiosk eating kideri, but he has 100 matatus on the streets. My answer is this. I'm not a health economist, but when we teach lawyers, we say we don't teach them law. We teach them how to find law. So I have some skills to also learn from other areas. And I have engaged with health for the last 4 years. And I have come by this information that 2 methods of pooling money to finance health. You can pool money using general taxes. People pay taxes, but the problem with that is that you leave health to go and compete at the table of budget making with the other departments that also want to be allocated money. And most of the times, the decision makers on budgets are public finance management people who do not understand the uniqueness of health. And we have not, us in the health sector, bothered to help them to start understanding the uniqueness of health. So quite often they allocate health less money than health requires. On the other hand, there is insurance, which we are saying is founded on the principle of voluntary contribution. And in an economy such as ours, where you have 17% salaried, it is easy for you to rate their salaries before they spend, you deduct. But when it comes to those who are in the informal sector, you don't know how to go about. That's why Dr. Abdi, they are struggling, means testing, Mara this, and they're not raising enough money. And I can tell you, they will not raise enough money. Kenyans will find a way to avoid. And so the best method would have been, it's good they are combining, but that combination of tax and insurance should have included earmarked taxes for health. So that the example you talked of, we do have road levy in this country, an earmarked tax for maintenance of roads. Now, the effect of that tax is that even those who don't have vehicles, they have to jump onto borders. If you increase fuel, your border because road levy, fuel levy has increased, the border will increase the fare. And this person who doesn't have a vehicle, by traveling on that border or a matatu, that person is very easily paying for health. And that man in Mathare who is eating kideri, who has 100 matatus, will have no way of declaring losses so that he does not pay what he is due to pay. Because as he fuels his 100 matatus, you are getting payment for health from him. So my answer is this. SHA did not solve the problem NHIF was facing. If NHIF was supposed to collapse in 2020, Dr. Abdi, your SHA is not going to go far. You may need to rethink the method of collecting money from the people in the informal sector.
Okay. Thanks, Prof. Doc, I'll give you 1 minute because I have many hands on this other side. Just
Yes,
1 minute.
I just want to say a couple of things. The first one is context. SHA is not the only financier of healthcare. It's very, very, very crucial that Kenyans understand that factor. We have several pockets, and Anita here is the expert. We have private insurance, we have employers who pay their staff, we have SHA, we have county governments, we have various other pockets. So it's important that we look at the entire bucket when we are discussing about healthcare financing. 2, there's a trust issue. Because if I give my money to any insurance, private or public, I expect when I have a claim event, the insurer will come through for me. And that the insurer is richer than me. And the insurer does not bring manenos. So when on one hand, people are queuing in hospitals, not getting dialysis and so on and so forth, and on the other hand, Dr. Abdi is telling Kenyans to pay, then they're asking, what will I be paying for? So we need to address the provider subsystem so that those who go to seek care can be evangelists, that indeed SHA works, so that they have a value proposition to pay for.
Prof, you have started a lot of comments from this side. So just 1 minute so that we come to our audience.
Thanks. So just to point out, I agree with Prof that SHA has not solved the problem that NHIF had, and that is the informal sector. You have not, and as predictions show, you will not solve. But when we say general taxes, have you ever looked at the breakdown of Kenya's revenue? The truth is that the biggest source of revenue is payee. So if you want to raise significant money, that would be your target, because that's your biggest source of revenue. If you go to VAT, how as a country with less than 20% formal sector, we collect less in VAT than payee, just beats me. It comes to honesty, accountability, and truthfulness as a country. Before we solve SHA problems, we have to solve corruption in this country. Thank you.
So that's the big elephant, yeah? So we'll get 5 questions or comments, then we come back to our panelists. So we'll start with you. So your name, any organization you're representing, and then if it's a comment or a question, you can start up.
Thank you. Dr. Joanne Osorombui, representing Kenya Association of Private Healthcare Providers. Panelists, thank you. It's a very honest conversation. I think mine, from a provider perspective, one is to appreciate that indeed the offering that's being given, when you look at the quality, you cannot compare with people like Ghana, as Dr. Abdi said. However, we do appreciate that even when it looks like it's very affordable, we say 300 per person, the amount that's being put in by the provider is significant. And ours is to request for more transparent conversation from SHA. Our 91% providers under 10 million, still we have a lag in closing out of those bills. If we can have conversations where we actually keep our word, we will start gaining on the trust that was eliminated. Dr. Abdi, you mentioned that in 2018, we providers kept giving even when we are not being paid, just a little. But there was goodwill. When we had Kenya at 50, celebrating NHIF, a lot of payment was made to providers during that time. And that goodwill built trust in the providers. And that's why, even if it came in bits, we knew it was coming. So ours is a request that for more conversation and even the reconciliations, we do not decline the investigation of the bills above 10 million. I think if we are to get rid of corruption in our country, that is required. And as providers, we support that. Just let's finish the process so that it doesn't keep going on endlessly. Thank you.
Thank you, Dr. Osoro, Kenya Association of Private Hospitals.
Thank you so much. I'll go to
this. Okay.
My name is Juliana Kingoro from Embakasi. I'm a community health promoter attached at Embakasi Health Center from Juakali Community Unit. What I'm requesting is that we are having challenges when registering the clients when they come in the facility, because we are on a community desk. When they just come, we say, do you have SHA? No, you start registering without knowing, because with the SHA people, they have never come in the community to sensitize the community. You know, when you come in the community and you do an activity, let me say a cleanup, we have a reflectors and you have attend somewhere with your staffs. When they, while doing the cleanup, they can just come and at least you educate them what is SHA, what is SHIF, what is Afyayetu. Because sometimes we don't have bundles, we register them, but it can't go through. Well, so when they come in the facility, they click in the portal, they have not paid. Sometimes they go, but for emergency, I just sang our facility. When they come, they are getting the attention first before they come, at least to continue registering. Others is that we are registering people, but when they go for payment, you know, in the community where we come from, there are some households which can't even afford. You know, a mother is a single mother, maybe her work is just going to wash clothes from the estate, and when the payment comes, you see that it's 800, 900, 1,100, so they complain, where do we get money? All the same on our side, we are community health promoters. We get a stipend of 3,500, and you are being told to pay 600. You have to pay the house rent, you have children, they go to school. So at least just come in the community level, educate the community to make our work to be easier, to do registration. And also at that time, you can do a lot of registration. It will be a mass registration, because the chiefs were just saying, come, register. You have a phone, continue. So many people, they don't know what is SHA, what is SHIF, what is Afyayetu.
Okay, thanks, Juliana. We'll take that. We have gotten that so that we give other people enough time. Let me pick from this side and one more from this side. There are the mics just behind you. If you don't mind just going to the microphone, and even on this other side. There's a microphone here. So your name, organization, and your comment or question. Let's start here as this other side gets ready.
Thank you. My name is Ken Aseka. I'm the editor-in-chief at the Kenya Times, and thank you for this platform. My questions are mwananchi kind of questions because of two reasons. One, I relate with SHA by virtue of having formal employment, so it's mandatory that the government chops off the 1%. But also I have...
Yours is 1%.
1 point, is it 7 or 5? Then I also pay for my parents, and I have gone through the means testing. So when Kenyans complain, I understand. So one, the registration process, for you to complete the means testing, you need to upload the documents you are uploading. Amulika Mwizi cannot do that. So was it the Ministry of ICT or CA that actually advised that we use that? Because the people in the villages have to either go to a cyber cafe to register. So why the Mulika Mwizi guys who are left out? I won't pay, I can't pay. How many people, how many Kenyans so far can't pay and won't pay? The president has repeatedly said that the government is paying for those people who can't pay and won't pay. And then Daktari from the private sector probably can tell us in terms of payment of debts owed to private hospitals, owed by NHIF, how far? Because I think there was some form of timelines that the president has issued. So kindly update us on the progress. Thank you so much.
Thank you, Ken. Let me go to the other mic, that side. Your name, organization, or who you're representing, and your comments in brief.
Sorry. Thank you. My name is Sarah Dagala from the Nairobi County Community Health Promoters. And thank you, panelists, for coming so that we can also share what we have from that level 1, where the primary health care needs to be very much in fully and in control. We have made so many submissions, but I'll just have to read because I've written somewhere, and I'll have to hand it for you so that you can also engage it further. And in case of any further clarification, you are available for that. That the key concern and observation. The rollout of SHA lacks robust grassroots consultation. True transformation must be bottom up. Recognizing the lived realities of millions who have been historically marginalized by the healthcare structure. There is urgent need for clarity on financing mechanism. Under SHA, will the poor, unemployed, and informal sector workers be forced through mandatory contribution without safeguard? UHC must not become euphemism for privatized or commodified healthcare. The SHA, while the SHA promises efficiency, centralizing authorities risk bureaucratic bloat and opacity. We demand independent oversight mechanism which representation from CHPs, civil societies, patients advocacy groups, and marginalized communities. SHA must guarantee that access to quality healthcare is not dependent on liability to pay, which contravenes Article 43 of the Constitution. The system must prioritize primary healthcare, preventive care, and promotive, not only wait until we go to curative and other chronic illnesses. And this is where primary healthcare, as a provision fund for level 1, should empower most CHPs. CHPs with a red bag, a phone, is not an empowered CHP, but one with the basic information on how to use those gadgets and kits that have been provided. The constitutional architecture mandates that health is devolved function. The SHA framework must respect and strengthen, not erode, county health system through resource sharing, coordination, and subsidiary. Lastly but not least, CHPs are a backbone of Kenya's public health system or response. SHA must formally recognize, remunerate, and protect CHPs essential healthcare workers and not as volunteers. SHA registration should be optional, not mandatory, as it stands right now. Then lastly, on the issues of the demand. Establish inclusive healthcare assemblies at the national and county level to ensure continuous public input in SHA policies, including budgeting and service design. Fund SHA through progressive taxation and ring-fenced public revenue, not mandatory contribution from the poor. Implemented wealth taxes and close corruption leaks in the health spending. Before full operationalization, conduct a public audit of all laws, policies, and regulations governing SHA to ensure alignment with the Bill of Rights and the principles of social community health promotions. Create a national scoreboard to co-develop with the citizen, CHPs, and health right NGOs to the SHA performance, equity outcomes, and citizen satisfaction. SHA must be insulated from political interference and electoral cycles. I'm just worried, after the Kenya Kwanza government, maybe if another government comes in, will we have another funding model for the health? So it should detract from political electoral cycles. We demand legislation that ensures non-discrimination, universally, and continuity of care rights. This issue of recovering payments, default members, just like the KRA, should be removed from the Act. We understand in the SHA Act that kama hutakuwa unalipa hii pesa, itakuja kuwa deni kwako with the penalties, na baadaye tena itabidi ukuje ufanye nini? Recover from your household, which you think it should not be a thing here. I now request to give you this document so that you will also go through it as we continue to critique the government on the same.
Thank you, Adagala from Nairobi County CHPs with a document for the chairman plus the contact so that you make sure you get in touch with him
to answer his questions, but I'm guessing you will touch on some of this. So let's take our last question here, then we come to the panel. Your name, organization, or who you're representing, and your question or comment.
Okay. Good evening, everyone. My name is Miheso Collins Lemashon. I'm the chairperson of the medical students of the University of Nairobi. Thank you for the invitation. I have two brief questions. Number one echoes around the issue of mental health among our providers with the rising burden that we have, pointing out inefficiencies with systemic support and preventive measures, just as we've heard from the registrars. So what deliberate measures is SHA putting in place to support mental health and well-being of healthcare providers, even especially those in trainings who are usually under immense pressure during this, and they're delivering services where we have resource constraint and overstretched facilities? A cousin question to that, maybe Anita can respond to it. With the current financial and constraints that we have within SHA and resource allocation shifts, how are you balancing cost effectiveness and quality of care, mostly in teaching hospitals where we are there at the moment, and we also see still we have such shortages of drugs as well as we have system failures? Thank you.
Thank you, Collins. Let me start with Anita as we come this side on that question specifically to you on cost effectiveness and quality of care.
So, Dr. Abdi is already laughing at my response. So as it is, I know that the government is working on a quality of care bill, and as the benefit package of SHA is currently structured, I have not seen any aspects of quality of care that have been incorporated into the benefit package. So we hope to see that going forward with the benefits advisory panel, measures to ensure that Kenyans actually get quality and that providers are held accountable to provide quality of care. In terms of cost effectiveness, some of these things are very political and very emotional as a country. For example, we would say that primary health care is more cost effective than high-end medical services. So that's another area where we really need honest conversations, where as it is now, SHA allocates, is it 4 billion or you've moved it to 7 billion now to primary health care, and almost 150 billion or whatever to social health insurance fund. Most of these funds should be going to the primary healthcare level to ensure that we actually get cost-effective healthcare. That is where most of the money is, to ensure we identify diseases before we treat. In terms of, I would just want to come back to Adagala on the social accountability part. I am a firm believer in social accountability, where the systems are open to all Kenyans. And I'm putting Dr. Abdi to task. We need to know how much you guys are generating. We need to know how much you guys are paying out, because we can't be paying 2.75% of our salaries for a black box. Kenyans need to be part of the table. We need to be part of the decision making, and we need to know how much is flowing and where is it flowing to. And in the same aspect of social accountability, the current systems lack trust. The only way to get more Kenyans to register is to give them a face that shows we are accountable and we are willing to do the right thing. And now that Dr. is coming just after me, one big challenge has been the private sector. Even as Doc is asking, when will you be paid? How fraud has been one of the serious cases of causes of lack of sustainability. As the private sector, are we willing to do the right thing to make sure that SHA is sustainable with whatever resources they have? Because it doesn't matter how much resources we raise. If the money will be stolen and it will not go to actually purchase healthcare, then we are not heading in the right direction. Let me end it at that. Thanks.
Okay. Thank you. Dr. Gakombe, specifically on how far the old debt is from payment. I know Abdi is saying verification is happening. Below 10 million will be paid, but the question is when, because it's been a recurring theme. And then you could answer some questions on the issues of transparency, openness. SHA uploaded a list of all hospitals that have been paid so far, and the next time when there was uproar, it was pulled down. Is that the kind of transparency that we are looking for?
Thank you. Payment is very far. Why? Because for the people who are promised 10 million, they are yet to see it. As far as I know, no one has received that money. And this being a presidential directive, it is very, very, very important that those who are directed to pay, pay. Because when a presidential directive is not implemented, then the remaining thing is anarchy. Because if the topmost person in a country can issue instructions and nothing happens, then where I come from, we used to have Mongeki as an alternative enforcement mechanism. And I don't want this country, because that was a terrible experience, to begin heading that way. So it's very, very important that that decision is executed quickly. Because for most of us providers, we are actually tottering on the brink of bankruptcy. We are not refusing to give care. We simply cannot afford to give care. I run an institution. The only reason it's open is because our bankers are standing behind us. They are funding us. Now, there'll come a time when they cannot fund us anymore, and at that point, we will just have to stop providing care. And it's important that that is understood, that this stoppage of service has actually been a cry for help, because most providers have maxed their overdraft limits, have maxed their supplier creditor limits. They simply have no more bandwidth to carry SHA, because we've been carrying NHIF from 2018, as you heard Dr. Abdi say, it's old from a long time ago. So we are simply, we've been running a marathon and we cannot cope. On the issue of honesty, the government runs DCI. The government runs the security apparatus. So we get extremely offended when somebody says you are stealing and nobody's in court, right? Because we are not encouraging good behavior. And I'll give you a very specific case. This is not SHA, this is NHIF. Metropolitan Hospital where I work caught a fraudster. Somebody came, we thought they were fraudulent, we called NHIF. NHIF came and arrested that person and took our medicine as exhibit worth 90,000. We neither got our medicine back, and neither was this person prosecuted. Instead, NHIF wrote me a letter. I still have it, saying, dare you attempt to be fraudulent again? So we need a system that recognizes, if you may allow me, one, that fraud is not a provider issue alone. It takes, this is not even two, it takes three to tango. The members, SHA, and providers. And there are very few providers who have set up hospitals worth billions of shillings with the primary intention of stealing from SHA. So let us prosecute the fraudsters and hold everybody accountable for their share of responsibility that they bear. Thank you.
Thank you, Dr. Gakombe. Abdi, you had the bulk of the questions. Juliana, on the issue of, basically awareness, education, and affordability when it comes to registration. And the same thing tied to what Aseka asked. On registration, you have to upload documents. If you have a Mulika Mwizi, what happens? And we saw cyber cafes charging people 500 shillings for registration, which is something that should be free. And is the government paying for people who can't pay, won't pay?
Thank you very much. There's something that I want to clarify, that this change was not just to change NHIF. There were 4 laws that were passed. One of them is what has entrenched the community health promoters. Primary Act. For the first time, government has community health promoters over 100,000. Prior to it, it was individual counties, some NGOs that used to have for vertical disease programs. So now we have an integrated, centralized community health promoters. Would I want them to be level 1 under SHA, given the powers? Yes. Why? Because they will help me prevent people from going to hospital and reduce the burden of disease and the claim payout by preventing at the household level. The second act that was passed is the issue of FIF, which allows to ring fence money meant for health to be used for health only. If I ask a question here, I'm sure none of you will be able to answer except maybe Mercy. Do you know who is supposed to sit in the board of management for level 2 and 3 facilities? That is dispensaries and health centers. The composition of the board that's supposed to manage those facilities. It's you, the public. The public has, women groups have a seat, youth have a seat, religious leaders have a seat, people with disability have a seat, the men have a seat. So basically, you are the ones who are supposed to oversight what happens in those facilities. That was also meant to help retain resources that they are used for what they are meant for. Because as we know, and as Prof clearly said, when people go to the table of the budget to make budget, people will always, other sectors will outcompete the health. Do we have, for the issue of Mulikamwizi, unless you have dependents, especially children, where you are uploading the birth certificate, as an individual, you don't need to upload anything. If you are registering yourself alone, you will just putting in your ID number and that's it. So there's nothing to upload. There's no ID number, there is no ID copy that you're uploading. It's only uploading comes in when now you are adding dependents. And that's children and maybe a spouse, where you need a document or something to show that truly that person is your spouse.
Okay.
So has the government prioritized in terms of the design of SHA? Primary health care fund is tax funded. It's free. And it's meant to address 80% of our health needs. 80%. And asked the allocation. The allocation is dependent on the number of people who have registered. The budget is 950 shilling per person who have registered per year. So the money comes in quarters. Unfortunately for SHA, we started when the first quarter was done. So we started second quarter of the year.
Okay.
Now we are the third quarter, fourth quarter have started. So subsequently, in the next budget, would we have money? Yes. Meant for primary health care. But we will not get 60 billion at once for all 50 million Kenyans, because it's not all 50 or 60 million Kenyans who have registered.
So it will be incremental?
It will be incremental based on the number of people who have registered.
Okay.
And that's how we will be able to address the issue of primary health care.
Okay. I want to pick two questions from our audiences online so before we just wrap up in the next 10 minutes. So one of the questions, and it will still come back to you, Abdi,
is on Steve El Sabay on Twitter is asking, why doesn't the government do major awareness and educate Kenyans about the Social Health Authority? Juliana asked the same, and also from our social listening surveys, we found out that there's big gap in terms of information. There's serious information asymmetry between SHA, or the people who know, and the general public. So that seems to be a major gap with SHA. Then the second question, I'll direct this to Prof, is about data protection. That biodata Kenyans didn't want to share with the previous government has been shared under this government. Is people's data safe now in terms of, what people are uploading or giving onto SHA? Is people's data safe? And you can tie that to, the Data Protection Act. So let me start with Prof, and then I come to Dr. Abdi.
Now, thank you. Of course, the issue of data protection is a major issue to worry about, especially if you go by what happened at the beginning of the year when Trump took the position he took and USID. It came as a shock to many of us that the systems we had been running around with telling Kenya KE, or whatever these we have established in health, we were not the ones storing that data. We can't even have access to that. So a president in another country says now no more of this, and we have no data.
You're stuck.
We have no access. Now, on that, I want to go to the issue of the problem we have with Kenya is that as Kenyans, we have become complacent to allow government not to do what governments are established to do. We are talking about equity. Dr. Musiega talked about salaries. Pay is what raises a lot of money. But what efforts are we making to reduce unemployment so that we have more people in employment? If pay is the easiest way to collect money, then we should be, as a government, working to get many of our people in employment. They are not doing that. Equity. As Kenyans, particularly elites, and something that started with Mzee Jomo Kenyatta, so many vijana ndio mpate kazi nzuri, we developed the escape mentality. Mimi nisome, nipate kazi nzuri, I escape from the problems of the rest of the society, and I can access private things. When the government cannot establish good public schools, we escape and take our children to the private schools instead of pushing government to provide good public facilities. When the government fails to put up good health facilities, we say, I can go to private. I can afford. We, the elites, are part of the problem. When some of us were growing up in the 70s and 60s, when you had visitors, if you didn't have cups and glasses and plates, you went to borrow from a neighbor. And one of the things that were included was a water jug. You put water in a jug with the glasses. Today, even in the deepest village, when they are budgeting for a funeral, bottled water. Because government has failed to provide good water. Now we are spending a lot of money on buying bottled water.
Okay.
That water is being bottled by people in government. They themselves don't go to those public health facilities. So we have to address some of those issues. If we want to deal with the trust issues, we have to see government officials using
this SHA. When we started making this law, they said it will be now equal to everybody. After a short while, the civil servants threatened, and they were given back the enhanced scheme. We can't run government like that. We are the civil servants making decisions, but we cannot use what we are offering you to use.
Okay.
It's wrong. Thank you.
Dr. Abdi, you look like you want to answer on the civil servant scheme. But before you go to that, you don't want to touch on but we have to ask it. We have to ask it.
I will answer on it. But I would say on the issue of Trump and the issue of the systems that we are using, it's not that we can't access that data. What has happened is the hosting is what the funding has cut off. But I would like us to give it to this government, because the vision of the digitization of the health sector is meant to address these kind of issues, so that the digitization is done by the national government and the data is stored locally and we have access to it with our own resources. It does not depend on any donor funding. And that's why we have created, and that was the fourth law that I did not mention when you cut me off, the Digital Health Agency. It's meant to digitize, including the electronic community health information system that the community health promoters, linked to the HMIS Dr. Gakombe uses in his facility, or currently Mombasa County that they use, and it's connected to the highway of information exchange. So for us, going forward, that data is with us and it belongs to Kenyans and it's with our own resources and it does not depend on any funding. The same way our community health promoters don't depend on any funding. On the issue of how the awareness.
Yes.
Since I became chair, SHA has been in the news every day. I don't know which day I have woken up and there is no news on SHA. That is 6 months. Whether it's good news, bad news, fake news, it's always in somewhere. Whether it is online, whether it's mainstream, whether it's headline on a newspaper. Sometimes I see a big headline, I get interested, I want to read what is the story. Then I go to the story. It has nothing to do with the organization. So sometimes I get surprised, I see something, then I ask myself, is this the same SHA where I am, or it is another SHA in someone's head? Because I don't see. What is written is far away from the reality.
So where is the gap then?
So the gap is there are people who have actively engaged in this information. And unfortunately, people have now that power on their phone. So I can post anything with no consequence. I can write whatever I want to write without anybody. I can say SHA is not working. That's good enough for it to spread everywhere. I can say I went to hospital and it paid for me only 1,000 while I never went anywhere. I didn't go to any hospital, I didn't go anywhere, but I can just write. And that's the
digital era that
the digital era and democracy.
What that means then, allow me to cut you, what that means then, because you say nature abhors a vacuum. It means SHA then has failed to populate the forums and the social media platforms and even the mainstream media with the correct information. It will create room for all the fake news that you're talking about.
Thank you.
I'll come to you, Doctor. So just in 1 minute, because we are out of time.
This is the thing. I would love to be in those all spaces. I would like to buy advertisement, publish, put billboards everywhere. Do you know, for SHA, our administrative cost has been capped to 5% by law. That I cannot spend, for every 100 shilling I collect, I can only spend 5 shilling to do whatever that I'm required to do, including paying salary, paying rent, doing advertisement, while NHIF had an open check. They used to spend as high as 20 to 30%. So they had the freedom to use whatever they had. For every 100 shilling they collect 30 shilling and use for whatever, with no limit. I only have 5%. So I have to use those resources prudently, and we are on a transition that we have found people that we need to reduce from the current 1,800 staff to 800.
I don't know if Dr. Gakombe wants to come to your rescue, but for where I sit, if the public is saying there's information asymmetry, they don't have the information, isn't that where you should prioritize the 5%? So that people can get the information. I don't want you to answer. I want to go to Gakombe.
Advertise and not pay salary. I have to pay salary first. Then subsequent things can come in. I can't have a guy who has not received salary and they can see adverts running on TV paid for by SHA. It's impossible. I have to prioritize.
Let's see if Dr. Gakombe is saving you on this
if I may help my little brother, my younger brother here. Number one, there is definitely a problem of communication, and it's great we are here because that should be part of addressing that issue. And one of the biggest challenges with communication is the 104 billion and SHA. Somebody, by accident or deliberately, combined two things that are not the same. So when people talk about SHA, they think about 104 billion. 104 billion sits somewhere else, and SHA is only one of the users of that system, and that needs to be clarified, absolutely. Finally, Dr. Anita talked about the need for transparency. When Kibaki was in the Nusumukate government, digitization was seen as a tool for distancing the corruptors and the corrupted through a digital link so that we did not have to meet face-to-face to engage in corruption. And two, to allow analytics so that we could attribute things to the people who were doing them. The reason I'm very supportive of digitization is that we can now see what Dr. Mwita here is doing, which hospitals he's practicing in, what he's pre-authorizing, what he's being paid for, and so on and so forth. And my hospital too. So for me, we will not succeed in the absence of digitization. If you may allow me 1 second.
The last one.
NHIF used to work. In fact, there was a reason there was a time it was not collapsing, right? It was solvent, it was buying plots, it was building expensive buildings, it was putting boardrooms for the CEO from here to the end of this stage, but it was only working for the people who worked there, right? Because it was spending, he's very generous. NHIF, when I started lobbying, was spending 90% of the money on itself and on corruption, and only giving 10% to service. That was in 2005. So it's been a journey to get him to 5%, and I want him to stick to that 5% and use the rest of the benefits for the people they're intended for.
Okay. Yes, Anita.
Okay. So, Dr. Abdi, I'm of a different opinion. I don't think you need 5% to tell Kenyans about SHA. Every morning, every day, hundreds of thousands of Kenyans visit health facilities for care. Despite the misinformation, as long as SHA does the right thing, which is provide the right benefit package and pay providers on time, who will ensure that the service is there. In the next 6 months, Kenyans will know for themselves what is SHA and what does SHA do for them. Thank you.
Thank you. Thank you very much, Anita, for that. I'll be remiss if I don't ask this question on the issue of civil servants and some employers, where they deduct the 2.75%, don't remit to SHA. I go to hospital, I think I'm paid up, and then I get to hospital, lo and behold, I am not up-to-date paid up member, yet my payslip, as Ken talked about, some 2.75% has been yanked from it. How do you go about this? Because the providers are not going to provide care if I'm not paid up to date. Yet now SHA has taken up, the pockets of civil servants, and then we have employers who are not remitting.
Prudent use of financial resources. I can't give you services for money I have not received. It's as simple as that. Whether you are employed by government or you are employed privately, we have provided an avenue for you to check eligibility at SHA, eligibility.sha.go.ke. You will be able to put in your ID. Even now, you will know whether you are paid up or not. For government, there's something we are working on to see whether that can be done, the deduction at source, so that it comes to SHA, so that when people get services, I can pay him. Because if I don't receive the premium, I will run into trouble. I will have no money to pay him. And that's where we don't want to go, the same problems NHIF used to face.
This to me presents a very big problem, because as an employee, I don't have an option to tell my employer, let me remit my 2.75% so that I'm able to access services. So I'm caught in between what Dr. Gakombe says, the devil and the deep blue ocean. What do I do as an employee if my employer hasn't remitted the funds?
So that is a compliance issue, and there's a penalty to your employer. So that now we are able to take it up with your employer. But for SHA, as I have said, everything that, including drugs not being available at the facility, is seen to be a SHA problem. While SHA's role is to pay for services. It's output-based financing. I don't do input. It's the provider who does the input, prepares everything. I only pay for services that you have consumed, that I have promised you. Communication, we keep on communicating. Yes, it's not enough, but you remember we are competing with fake news and our news. So it's a continuous challenge that we face, which is running parallel. But as time goes on, we have realized Kenyans are not listening, because what's happening is, on average, I receive up to 50,000 people registering daily. So that shows you that if this thing was so bad, as constantly communicated by other people, then why would someone register? And if you remember my beginning, you need health from cradle to grave, and it's personal. When you are sick, you're on your own. Mm-hmm. There's no one you share with that health. Mm-hmm. So Kenyans, we will keep on going, and we have a long journey in terms of continuous engagement, this being one of them, that we keep on addressing, always demystifying the false from the truth.
Okay. When our time was up, many points were coming to mind. Let me go to Prof here, and then Doc.
Just a last point. The point you have raised of failure to remit deductions is not just for SHA alone. It is actually a time bomb waiting to happen in this country. And it's part of what I am calling failure of governance. They deduct, even pay, they don't remit. They deduct pensions, they don't remit. They deduct even SACCO contributions, they don't even bank loan repayments. And most of them are government organizations.
Yes.
Go to our public universities now. That is the same problem in all of them. There are many people on the verge of retiring who will find they have no pension to retire on. We must look the government in the eye and tell them, you can't be making laws for the private citizens to comply with, and you can't enforce those laws among government institutions. It is criminal for employers to deduct money from employees and fail to remit. It is criminal. Government ought to move in and act on that, because we can't continue like that. It is not just for SHA, it is everywhere, and it's a time bomb coming to happen. Thank you.
Thank you. Doc, I'll give you just 30 seconds just to respond. So if my employer hasn't deducted, I'm sick and I've come to your facility, what happens to me?
I fully understand Dr. Abdi's sentiments, but there is a problem, and the professor can help us because this is a legal issue. SHA appoints employers as its agents by law, because it's not employees who choose how their money is remitted. SHA decided its wisdom, or the government of Kenya, that money will be deducted by X. My little understanding of law is this, that if I give something to your agent, and the agent fails to give the money to you, it is not my responsibility. Some of us here are tenants. If you pay the agent of the landlord, and then the landlord comes to evict you, it is a major problem. So I understand where Dr. Abdi is coming from. We have had a structural problem, and Prof has talked about it. It's an issue we need to address, because my cleaners, my nurses do not have the power to force me to give SHA money. So whereas I understand why he wants to have money, he's the one with more power than the employee. So we have to find a solution. And it will create a major trust issue. And it means that UHC is not working, because the overriding objective of UHC is to stop paying out of pocket. So if somebody who paid their premiums is still paying out of pocket, it's a fundamental failure of the system. Tutaongea na Abdi, hiyo kitarudiwa hiyo.
We will keep tabs on it. Lady and gentlemen, thank you for your time. We have overrun by 15 minutes, but I think it was valuable conversations. And the good thing is that for Willow Health Media, this is the first of several county town hall conversations on SHA, because we want, as we said, to come to the people. We want to come to you to have these conversations so that you have the opportunity to raise some of these issues, either directly when you're part of the audiences or online or through us. We close this impactful dialogue today, but one thing is very clear, that there is progress, as Dr. Abdi has said, in the 6 months, but there are many challenges that persist. You've been challenged by Anita on the part of education, creating awareness. And from where we sit as communicators, it should be a priority, because you can have a very beautiful policy, but if people don't understand it, then it fails on the spot. So the challenge is on to you. The legal experts are here. Thank you, Professor Kangu, for your valued input and giving us a broad perspective from a societal point of view. Thank you, Dr. Abdi, Chairman SHA. Thank you, Dr. Gakombe, as a provider and representative of the Kenya Healthcare Federation, and of course, Dr. Anita Musiega, our health economist and
for your valued input and giving us the other African perspectives. For our audiences, both here on the town hall, at Kemri and also online, we'd like to have your feedback on this event. Go to our website, willowhealthmedia.org/events, and give us your feedback, because we value your feedback and it will help us shape the other town hall conversations that we'll have. Our next conversation will be in Kisumu City, and we hope that we can host you there, you can host us there, and that we can have another valued conversation. It will be a continuation from what we've started here. Don't forget to follow us on all our social media platforms. Our handle is Willow Health Media. Thank you for my colleagues from the Fourth Estate. We have 17 different media houses, both mainstream and digital like ourselves, represented here. We value your time. For our students from the various universities, Kemri that has hosted us here, we thank you very much, and all the doctors that have made time this evening. I've been your host, Dr. Mercy Korir, the CEO of Willow Health Media, and we look forward to further conversations on SHA, because we want to understand where the gaps are and if we can make progress together. Thank you very much.